Thank you, guys. My name is Jimmy Lau, the Director of Nursing for Renown Regional Emergency Services and of the Crisis Care Center. First off, I want to say thank you for your ongoing partnership and collaboration with us. Last year, we saw a total of 120,000 just in our ED alone, and that puts us at number 20th busiest in the country and the busiest in the state of Nevada. And also the role that you guys play in our EMS review with reviewing cases that you guys transfer over to us or other EMS agencies so that there's shared learning that's happening. So hopefully that's working out well for everyone in all fire and EMS agencies in the local community to improve the quality of care that we're giving. I'm here to talk about the Crisis Care Center when we've reopened it. Last year, we were able to open it the first time, but we were only open for 5 weeks, and that was because of the Department of Government Efficiency work. They pulled our funding, we had to close it, and we were incredibly saddened by that decision. But it gave us time to regroup and really just look at what the best approach is when it comes to having this resource for our community. The Crisis Care Center was built for patients experiencing mental health and behavioral health crisis with or without substance use. Naturally or normally, these patients would go to the ED for any mental health or behavioral health services that they need. However, it's not a therapeutic environment for them. Most of the time, they are locked into a room with a sitter right outside, and they're not getting better. Sometimes they're not getting seen by a psychiatric nurse practitioner or a behavioral health therapist right away. And oftentimes it results in a violent outburst, and they would end up going to jail. For the extreme cases, they would go straight to jail just because of the behavior that they're demonstrating and hurting other people, hurting law enforcement. And so this is why we developed this. What I'm going to show you is one aspect is you guys might be transporting patients experiencing mental health crisis in collaboration with Sparks PD and Sparks Most. The second piece to it is I wanted to show you guys how what we thought about how we can serve those who are serving other people. So the alternate destination protocol, this is embedded in the EMS, Washoe County EMS regional protocol, but it does clearly delineate the eligibility criteria and the exclusion criteria for the services that we provide. Vital signs are embedded in it. The age of the patient is embedded in it. It also talks about not having any walking aids and the absence of a medical clearance for a patient, and for patients who have given multiple doses of naloxone. Obviously, we can't take them, but a single dose naloxone, they're good to come to the Crisis Care Center. The picture on the upper right-hand corner over there is the therapeutic milieu that we have. We have 15 seats and 10 rooms that we can play with. The patient has the ability to move around the facility and engage other patients and engage our staff members. And there's not a lot of partition between the patients and the staff. This is our nurses station. And so that therapeutic milieu works really well for patients in a mental health crisis. Our staffing involves a 24/7 psychiatric nurse practitioner, 24/7 behavioral health therapist. The behavioral health therapist role has one of the three licensure. We have a licensed clinical social worker, we have a marriage family therapist, and we also have a licensed clinical professional counselor. So we just hired our first MFT, but majority of our behavioral health therapists are licensed clinical social workers. On the next slide here is the exclusionary criteria. We were able to trim this down from 12 items to 5 items, and we were very precise in making sure that we're not too restrictive on the patients that we're able to see. These are the vital signs parameters that we're able to take, and it should give you a good idea on what would be good for the Crisis Care Center versus the ED. To simplify all of this, we developed a crisis field assessment screening tool. 9 questions directly tied to our inclusion and exclusion criteria. And the format is very simple. It's yes or no to each question. It has to be no on all of the questions in order for us to take that patient to the crisis care center. If it's a single yes, then we will have to direct you to the nearest emergency department. So the first one is based on age. The second one is are they disoriented to name, place, or time? That really is trying to rule out if there's any traumatic brain injury or any condition that may warrant further medical screening for them. Is the patient in their third trimester of pregnancy? These patients are definitely needing additional resources. Does the patient require an assistive device like a walker, cane, or wheelchair? Those items can be used as a weapon towards other patients or towards staff. Does the patient require report any physical illness? We want to make sure that they get medically screened first in an ED. Or does the patient require oxygen? We don't have oxygen at the crisis care center, but we have a couple of oxygen tanks reserved for patients who are medically deteriorating. Those patients are just waiting for them to be transported out to the nearest emergency department. Has the patient reported vomiting, diarrhea, fever in the last 12 hours? We want to make sure that we rule out any infectious disease. And then, does the patient require physical or chemical restraints? If the intent is for the safety of the patient, safety of the transporting team, and safety of the staff, then they need additional resources and they need to go to the ED. So those 9 questions, we put them in a calling card or a business card. I'll make sure Duke will get them and be able to distribute them everywhere. That way, when you have a patient in a mental health crisis, then you can screen them with us. First thing you need to do is just call our number 775-982-HELP or 4357, and we'll go through the screening process with you. Any questions with that? So far, we're averaging a total of maybe 10 patients per day. We will have our highest number month since we reopened on November 11th. Right now, we're on track to finish the month with 277 patients. And so we're definitely saving a lot of room time for the ED and be able to transfer those patients from ED to us, or at least for transporting agencies, they're able to get to a place to where they can drop off easily. We do have a no wrong door policy. If you show up without even calling us, we'll take the patient, and then we'll figure out what to do with the patient. We also have a goal of drop off time of less than 5 minutes. We're averaging right now 2.5 minutes in being able to hand off from fire or EMS agencies to us, and securing that patient and getting them inside the crisis care center. When we built the crisis care center, we thought about, with this service, how can we serve those who are serving the community? And how can we make a bigger impact for our law enforcement agencies, EMS agencies, and other brothers and sisters that are out there? We obviously are intending to take over or replace the services that we get from Peer Support or the Nevada Peer Support Network. This is in partnership with them. This was inspired by a law enforcement agent in the community who was in a mental health crisis a couple of years ago. Went to the ED, needed help, walked into the ED, immediately turned around and walked away after they hit the lobby. They went back to their car, they sat in their car, and they cried, and they did not get the help that they needed. When I found out about that, it was a heartbreaking moment for me because we could have done better for that person. They turned around and walked away from that lobby because they saw someone that they arrested the week before. So the intent of the Code Phoenix is for you to have a discreet, private, and confidential access to the crisis care center. You call 775-982-HELP. We'll direct you to the crisis care center. As soon as you arrive, we will direct you to the back door inside the private room. That private room has its own bathroom, and everything will be done for you there. The biggest piece here is you'll be checked in under an alias. You won't be mixed in with other patients, and you'll get to see one of our psychiatric APRN right away and our behavioral health therapist right away. To date, since we've opened on November 11th, we've used this 30 times now, and the patients that we saw span from healthcare professionals, law enforcement agents, EMS agents, firefighters, and military servicemen. And so one of the things that we are aspiring to do is our approach is also always trauma-informed and culturally competent. And so I have reached out to all of the local fire agencies, EMS agencies, and law enforcement agents to allow my team to be able to do ride along and immerse and spend at least 8 hours with you every quarter, so that we can get acclimated to your culture and how you support each other, and the stress and the things that makes you unique as a first responder out there. And so I've reached out to Carson Fire and Reno Fire. They were willing to do it. I'm also going to ask you guys if this is something that we can do as part of our cultural competency, so that we can get to know you guys. And any questions? The natural path of this is, if someone is struggling, obviously one of your peer supporters would approach that person, provide them support. And if that person is truly in a mental health crisis, you'll also try to reach out to Nevada Peer Support Network if they can help them or get them in. But for the ones who are outside of their reach, or who needs immediate attention right away, then think of us, and we want to be that safe place for you guys. We have started our alcohol withdrawal protocol. We can start early alcohol detox management. Sometimes we say that we can keep a patient up to 24 hours, but we have kept patients for up to 48 to 72 hours, just so we can get them through that detox phase of their alcohol withdrawal symptoms. We've also turned on our opiate withdrawal protocol, and so we're evolving, and we're getting more complex. We have our own addiction medicine service, a physician that is specializing in addiction medicine, so that would be part of the service that we're providing.
Is this service available for retirees?
Yes. Yes.
Is there a large difference between you guys, what you're doing, and Reno Behavioral Health as far as like resources available, or it seems like a similar model for the patient side of it?
The patient side of it, there's a lot of similarities, but the difference there is they have the inpatient psychiatric section. We don't, and what we do is we would work with the patient in an intensive fashion. They are receiving intensive therapy to get them out of that crisis. Not reflected, or I haven't really shared it with everyone, but out of the patients that we put on an involuntary hold, we're able to convert 55% of them to voluntary status and be able to lift that hold and be able to release them back out to the community with appropriate resources. The biggest thing here is we try to work with the patient and their support system so that they don't have to be admitted to an inpatient psychiatric facility that could hold them up to 72 hours or longer. Yeah, they do, and we're averaging. We started with average of 1 transport from them a day, but now we're up to 3 patients per day for them. So yeah. Actually, there might have been an instance, not you guys, but most will tell you that this patient should go to the crisis care center. with the screening tool that we developed, they were part of that development and they gave us a lot of feedback. And so um, there is a dual response with patients with mental health crisis with FHIR and MOST, right? So oftentimes you guys are together.
Yeah, we typically we request them, I believe.
Yeah.
Yeah, it's not always just like an immediate discussion.
Yeah.
Or as I understand.
So when it comes to the decision to transport a patient, would that be you or would that be MOST?
Whoever you see most. so
Usually
good.
most is, they're kind of like aware of who they're keeping an eye out.
I see.
So they're pretty good about, we had a call yesterday where we had no, I had never seen the lady pulse notices here before, so they just coordinated around to, oh yeah.
I see.
So here's her usual hangabouts and then that.
Yeah.
I think they had taken her to just Mount Maine.
Okay.
There's some medical concerns there.
Yeah.
But usually Sparks, PD most is good about knowing who they're dealing with.
Yeah.
Yeah, not available.
Yeah.
What's the average amount of time that people stay admitted at the crisis center? Is it 72 hours or is it much longer than
The
that?
goal is for us to keep them 24 hours. We're averaging 21 to 22 hours right now. Naturally, we want to make sure that before we discharge them, we have a safe plan of care for them and we've connected with their collateral and support system. But the 21, 22, it's rare that we would keep a patient that long. And oftentimes it is a result of the inpatient psychiatric facilities are full or they're not staffed for us, for them to be able to take our patients. We also have our financial assistance program for the ones who do not have the ability to pay. We will take them regardless. Then our financial assistance program will help them with the application process. With that program, we can also cover up to 30-day supply of their medications if they are put on a new prescription for their condition.
I mean, this might have been in your previous slide, but you take people that are on holds, right?
Yes.
Okay.
Yeah. If you put them on a legal hold, we'll take them as long as they meet the criteria.
So they still have to meet all of the, like, can't be restrained, it has to be
Yeah.
voluntary. Okay.
Yeah. Yeah.
One of the exclusionary criteria was like vomiting within 12 hours beforehand.
Yeah, vomiting. Vomiting within 12 hours, and so if they have been vomiting, then we just need to be able to medically screen them. But it also is based on, are they vomiting because of alcohol intoxication?
Yeah, that's what I was gonna say.
And so we would leave that decision making for you guys. Bring them in, and then we'll take care of them.
Or that, like, we call you and
Yeah.
say, hey, this is what we have, like,
Yeah.
can you guys take this patient? And are you talking to a nurse when you call, or?
You're talking to a nurse when you call.
Okay.
Yeah. So Duke has my number, and if you guys need help with or have any questions or any suggestions on how we can make this better, we definitely are open to any ideas or suggestions.
Are you?
The other thing you have, the Code Phoenix,
Oh.
whatever it is, do you have like, since it's for first responders and everything, do you have like cards or pamphlets or magnets or something like that that you've been handing out to like agencies
Yeah.
so that they have like a quick reference to be like, here's, or something like that?
Yeah, I'll get them to do so that he can distribute them to your stations. 6 stations, right?
6 stations.
6 stations. Yeah.
Any questions? Everybody's journey? Cool, thanks, Jimmy.
Thank you guys. I appreciate all the work.